Thanks for introducing me. Today, we will be talking about surgeries of the ear. I will be mainly talking about the surgeries which we routinely do in our practice and which every resident who comes out of the medical college or an institution from where he is trained is required to do it. So, I will be talking about the basic surgeries of the ear. Um, Most of the surgeries are we of the year we do of the middle ear surgeries. So yeah, first surgery. Okay, first surgery is the myringotomy. As the name suggests, as you know, what is otomy? Otomy is opening up of anything, and the myringotomy means you open up the tympanic membrane. So it is the incision of the tympanic membrane with the purpose to drain suppurative or non-suppurative effusion of the middle ear or to provide aeration in cases of malfunctioning eustachian. Sometimes the ventilation tube or grommet is also inserted in cases where there is effusion or there is a malfunctioning eustachian. So varigotomy is essentially opening up of the tympanic middle ear through the tympanic membrane. Okay. Now, what are the indications of myringotomy? Why, when we are required to do a myringotomy? As you know, there is an entity known as acute suppurative otitis media. It is an acute inflammation of the middle ear, in which when there is a patient who comes with a severe earache with bulging of tympanic membrane. So in that case, you need to perform a myringotomy so that the pus which is formed behind the tympanic membrane can be drained out. Next indication in this category, acute suppurative otitis media cases, when there is an incomplete resolution of this acute suppurative otitis media, along with opaque drum and persistent conductive deafness. It means there is still some fluid left in the middle ear, which is causing the conductive deafness. So, in those cases, we again perform the laryngectomy. And when there is complications, so there are complications of acute otitis media, such as facial paralysis, labyrinthitis, or meningitis, and the tympanic membrane is also bulging, then we need to perform a laryngotomy so that the pus can be drained out and these complications are easily managed. In cases of non-suppurative inflammation, like in cases of serous otitis media, it is also the serous fluid is to be drained. In cases of aerotitis media, the other name is barotitis media. Baro means because of pressure changes, if the middle ear, the eustachian tube gets locked, gets blocked. So there is a collection of fluid, and we have to unlock drain the fluid and unlock the eustachian tube. In those cases, aerotitis media. In cases of aerotitis media, it is done, and in cases of atelectatic ear, in which the tympanic brain is almost adhered and fixed to the promontory. So in those cases, parigotomy is done and a groma is inserted so that the aeration of the middle ear can happen and the tympanic membrane may become normal there. Okay. So what are the contraindication of this when we do not try to perform the myringotomy? When we suspect any intratympanic malignancy, intratympanic tumor, like in cases of glomus tumor, it is a highly vascular tumor, arises in the tympanic cavity. If you accidentally perform a myringotomy, it will cause profuse bleeding. Okay, so in those cases, myringotomy should not be done. At least you should be preoperatively evaluating the case as if the patient does not have this glomus tube. Okay, in those cases, the opening up of whole of the middle ear means tympanotomy. Opening up of middle ear is preferred. Okay, how we do it? We do it in general anesthesia in cases of children and infant. In adults, general anesthesia is used only when tympanic membrane is severely inflamed And if the inflammation is minimal, laryngectomy can be done under local anesthesia. What are the steps of operation? How do we do it? Actually, we clean the ear canal of wax and debris. If something is there, we have to remove it. We have to clean it. Then we perform this operation under operating microscope. But in your practice or now, right now, usually we do it with endoscopes. 0 degree endoscopes, oral endoscope, ear endoscopes are there. We can perform with those. We use a sharp Maringot bone. It is a sharp knife-like instrument, and a good suction apparatus is very much required. In acute subhepatitis media, we make a circumferential incision in the posterior inferior quadrant of the tympanic membrane, midway between handle of malleus and tympanic annulus, thereby avoiding the injury to the incurvestibular joint. In cases of serous otitis media, we put this incision in the radial type, and a small radial incision is given in the posterior inferior or anterior inferior quadrant, and all the infusion is sucked out. And if there is need, we put a ventilation tube or chroming. Okay, these are the photographs depicting the incision placed in the on the tympanic membrane. As you see, this is the whole of the. Okay, let me just turn on the pointer. Okay, you can see this is the tympanic membrane. This is the handle of malleus. This is anterior malleolar fold. This is posterior malleolar fold. This is attic part. This is pars tensa part. So we put a radial incision like this in cases of otitis media with effusion or serous otitis media. In acute suppurative otitis media, we usually prefer posterior inferior quadrant incision, which is along the transverse curvilinear incision. Okay. This is how we put a chromate. After putting this incision, we put a ventilation tube or chromate. Now, what are the pitfalls of laryngectomy when we cannot do the laryngectomy, when laryngectomy fails? When there is a excessively thick tympanic membrane, when you give an incision, incision may remain only in the superficial layers of the tympanic membrane without cutting through its entire thickness. So you have cut, but the incision has not reached till the last layer of the tympanic membrane, and the laryngectomy fails. Sometimes there's so much of inflammation, the distinction between the tympanic brain and the posterior meatal wall is lost. So you may wrongly give an incision in the posterior meatal wall, and the laryngectomy may fail. So these are the things which you should avoid, and you should look properly for the uh, tympanic brain, and if you do not suck anything, if you are not able to suck, make sure that the incision is deep enough to cut the entire tympanic brain. Okay, how do we do a post-operative care in these cases? We do daily mopping of the ear discharge in cases of acute suppurative rhinorrhea, because the discharge comes out through the perforation into the incision which we have created. In serous otitis media, if you just suck out the effusion, usually the uh, ear becomes dry. Incisions heal very rapidly. If you do not put a chromate, the incisions heal in 3-4 days. The first condition is this: water should not be permitted to enter the ear canal, otherwise it will cause the superadded bacterial infection. And if a grommet has been inserted, it comes out. Uh, Entry of water should be restricted until the grommet is in the position. Usually, grommet comes out by itself in 4 to 6 weeks' time. What are the complications which you may encounter? You can have injury to the intercostable joint or stapes if you wrongly put the incision superiorly. If the jugular bulb is dehiscent, you can injure the jugular bulb. you will end up with profuse bleeding, and there may be a middle ear infection if the you the infection enters in the middle ear. So this is the all about laryngectomy. So now we go from membrane surgery of the membrane to the surgery of the middle ear. So there are terms with different terms, different operations which we perform for the chronic ear infections. So I'm just making you aware of these terms. What is laryngoplasty? What is tympanoplasty? What is mastoidectomy? So let me just give you some definitions. Laryngoplasty, when you say, I have done a laryngoplasty or he is doing a laryngoplasty, it is an operation in which the reconstructive procedure is limited to the repair of tympanic membrane perforation. Tympanic membrane is perforated. If you only repair it by any mean, by dura, by graft, by vein graft, it is a laryngoplasty. When we say he is doing tympanoplasty without mastoidectomy or tympanoplasty, simply tympanoplasty, tympanoplasty means tympanum is middle ear, means middle ear reconstruction. In this, we eradicate the disease in the middle ear and reconstruct the hearing mechanism without mastoid surgery, with or without tympanic membrane grafting. This is the definition of tympanoplasty without mastoidectomy. This means ossicular reconstruction only or ossicular reconstruction with myrinoplasty. Both are known as tympanoplasty. Okay. Now, when we say tympanoplasty with mastoidectomy, it's an operation in which the disease is eradicated from both the mastoid and the middle ear cavity, and hearing mechanism is reconstructed with or without tympanic membrane grafting. When we say cortical mastoidectomy or simple mastoidectomy, or another name is Schwartz operation, it is an exenteration of all accessible mastoid ear cells, preserving the posterior meatal wall. In this operation, we remove all the mastoid ear cells in which they disease or non-disease. We do complete exenteration of all accessible mastoid ear cells and preserve the posterior meatal wall, in which, in this case, in this operation, we do not do anything in the middle ear. Okay. Now, what is modified radical mastectomy? Modified radical mastectomy, it's how mastectomy, simple mastectomy, you understand. Okay? When we do modified radical mastectomy, in this we eradicate the disease from the attic and the mastoid. Okay? And both of which are exteriorized into the external auditory canal by removing the posterior meatal wall and lateral attic wall. Okay? The tympanic membrane remnants, functioning ossicles, and reversible mucosa and functions of eustachian tube are preserved. And these structures, by using these structures, we reconstruct the hearing mechanism at the time of surgery or in a second stage operation. ठीक है? So modified radical mastectomy हम क्या करते हैं कि हमने we eradicated all the disease from the mastoid and attic. Both were exteriorized into the external canal by removal of posterior meatal and lateral attic walls. Take all the functioning ossicles, remnants of the tympanic membrane, the mucosa which is reversible. Reversible means जो कि repair ठीक हो सकती है. And eustachian tube functions. Eustachian tube function, eustachian tube को हम preserve करते हैं और then these with the help of remnants, with the help of functioning ossicles, we do a ossiculoplasty and tympanoplasty. Okay, and at the time of surgery or in the second stage. In radical mastectomy, in contrast to the modified radical mastectomy, but radical mastectomy is the first operation which was performed for the ear infections. But what was the problem? In this operation, we eradicated disease from the middle ear and mastoid complete eradication of the disease, complete eradication of all the mastoid hair cells, complete eradication of the posterior meatal wall. The are because of that, the whole of the mastoid is externalized into the external ear. The all the remnants of tympanic membrane, whether they are healthy or unhealthy, malleus, incus, the stipes, not the stipes, but chorda tympani and mucoperiosteal lining of whole of the middle ear and mastoid, and the opening is removed. Okay, and the opening of the sticking tube is also closed by backing a piece of muscle or cartilage into the sticking tube. So we make a cul-de-sac out of the ear and eradicate whole of the disease, but leave the ear functionless because of you are not doing any reconstruction. So right now, the radical mastectomy is not performed routinely. We usually prefer modified radical mastectomy. Now, one more thing, modified radical mastectomy has two variants. One is canal wall up and canal wall down. In canal wall up, we do not remove the posterior canal wall completely. We just uh, try to remove the disease and preserve the posterior meatal wall. So, and in canal wall down, as I've written, we remove whole of the posterior meatal wall. But in canal wall up surgery, the chances of recurrence are very high. So that is not preferred mode of surgery. Now, what is meatoplasty? Meatoplasty is an operation in which a crescent of cochlear cartilage is excised to widen the meatus. We widen the meatus. Okay? It is usually combined with all canal wall down procedures because we are making a big cavity and taking away the canal wall. So they has to they have to have a big meatus so that we can look into the cavity. So we can periodically clean it, inspect it, and we can easily access it. Okay. In what is mastoid obliteration? In this operation, we eradicate the mastoid disease like in MRM, and we after that we obliterate the mastoid cavity by pedicle temporalis muscle, musculofacial tissues, or some other materials. There are many methods. So, what are the surgical approaches to the ear and the incisions? So, first surgical approach is endomeatal or transcanal approach. It is used to raise a tympanomeatal flap in order to expose the middle ear. As you can see, this is the tympanic membrane of right ear. This is handle of malleus, and you give an incision at 12 o'clock, going up to the 6 o'clock in the curvilinear fashion. Okay, and this incision usually is used for the small work like tympanotomy, exploratory tympanotomy in cases of stapes surgeries. This is performed. Okay, for conductive hair loss, sometimes for inlay myringoplasty or ossicular reconstruction, it can also be done. Now, the endoral approach, next is approach is endoral. Endoral is used for excision of osteomas or exostosis of the ear canal, for the large tympanic membrane perforations, for attic polystomas, which are limited, which have limited extension into the antrum, for the modified radical mastoidectomy, where the disease is limited to attic, antrum, or superior part of mastoid. And endoral approach is made through Lampert's system. This approach, this transcanal approach is made through Rosen incision. Endoral approach is made through Lampert's incision. It consists of two parts, Lampert 1 and Lampert 2. Lampert 2 is a circular incision made from 12 o'clock to 6 o'clock position in the posterior wall at bony cartilaginous junction, as is seen in this diagram, but it's somewhat superior to this, somewhat lateral to this, at the bony cartilaginous junction. Lampert 2 starts from the first incision at 12 o'clock, means in the center of the superior canal wall, passes upwards in curvilinear fashion between the tragus and the crux of helix. In the comes out of, through the incisura terminalis and goes up to the uh, temporal region. So, since it passes through incisura terminalis, it does not cut the cartilage. Both mastoid and external canal surgery can be done by endoral. Now, the post-oral or Weil's incision is the most commonly used incision for mastoid or middle surgeries. It starts at the highest attachment of pinna, follows the curve of retroauricular groove, just lies 1 centimeter behind it, and ends at the tip of mastoid. In infants and children up to 2 years of age, mastoid process is not well developed, so the facial nerve lies very superficial and exposed. So the incision therefore is slanted posteriorly and uh, avoids the lower part of the mastoid. Post-oral incision is workhorse of the all the incision of the middle ear surgeries, middle ear or ear surgeries. It is used for every surgery in the middle ear. Cortical mastectomy, we can do modified radical and radical mastectomy. We can do all the tympanoplasties. We can do exposure of seventh cranial nerve in vertical segment. We can do surgery of the endolymphatic sac. We can do everything by this. This is the workhorse post-oral or wild incision. So how do we do a Lampert's incision? I have shown you like this. Then goes upwards, comes out like this. Post-oral incision is classical incision is B, which you are seeing. Some people, surgeons prefer to give it in the post-auricular groove. And in infant and children, you can see this C type of incision which does not go tip the tail of tip of mastoid and goes posteriorly instead of going directly inferior. Now, what is cortical mastoid? I've told you what is cortical mastoid. I've defined it. It is a complete mastoidectomy or simple mastoidectomy or Schwartz operation, in which we do a complete excitation of all accessible mastoid hair cells and convert them into a single cavity. Posterior meatal wall is left intact and middle ear structures are not disturbed. The indications of this surgery are acute coalescent mastoiditis, incompletely resolved acute pruritus media with reservoir sign, masked mastoiditis, and as an initial step to perform endolymphatic sac surgery, decompression of facial nerve, translabyrinthine or retrolabyrinthine procedures for acoustic neuroma. And also the cochlear implant surgery. We need to do a cortical mastoidectomy. How it is performed? It is performed with general anesthesia. Patient lies supine with face turned to one side and the ear to be operated is held up. Steps of the operation, the incision is given, post-oral or endoral, whichever the surgeon like. Expose the lateral surface of the mastoid and the McEwen's triangle, which is very important to know the area where the mastoidectomy lies. Periosteum is incised in the line of first incision. Self-retaining retractor. After applying the self-retaining mastoid retractor, remove the mastoid cortex, expose the antrum. Cortical bone is removed with a burr, gouge, or hammer, and mastoid antrum is exposed in the area of suprameatal triangle. We remove all of the mastoid hair cells, remove the mastoid tip, and finish the cavity. Okay, zygomatic cells are also removed. The finished cavity should have beveled edges so that the soft tissue can easily sit in and obliterate the cavity. Usually, a drain, if required, can be given at the lower end of the incision, and a pack and dressing will be applied. So, what if we do like this? This is the whole of the mastoid cortical mastoidectomy cavity looks like. This is tegment tympani, this is sinus plate, this is the labyrinth, this is the horizontal semicircular canal, and this is the facial nerve. You can also see the short process of incus. Okay, so all of the mastoid cells are removed. but we preserve the posterior meatal wall. This is the posterior meatal wall, this one. Okay, we preserve it. We, as antibiotics and drain are to be taken care of, and stitches are removed on the 6th or 7th day. The complications, you may injure the facial nerve, you may dislocate the incus, the injury to the nose and semicircular canal may occur, and patient will have postoperative vertigo and nystagmus. You may injure the sigmoid sinus, which may cause profuse bleeding. The injury to the dura of middle cranial fossa can occur, and sometimes postoperative wound infection, wound breakdown may also occur. Now, radical mastectomy. In this, we eradicate the disease. I've told you all the remnants of membranes, temporary membrane, ossicles, except stapes footplate and mucoperiosteal lining are removed. Histogeny is obliterated by a piece of muscle or cartilage. The aim of this operation is to permanently exteriorize the diseased area for inspection and cleaning. And as I've told, radical mastectomy is infrequently required these days because of better procedures. So, what are the indications? When all the cholesteatoma cannot be safely removed, all the disease from the middle ear, cholesteatoma cannot be safely removed. The cholesteatoma which is invading the ischemic tube, going into the round niche, perilabyrinthine or hypotympanic cells, it cannot be safely removed. So we do a radical mastectomy, open up and inspect the cavity lifelong. If the previous attempts to eradicate chronic inflammatory disease of cholesteatoma have failed, means you have done a radical mastectomy, modified radical mastectomy, but there is again recurrence. So you have to perform a radical mastectomy. Sometimes for the approach to petrous surface, sometimes there is a cholesteatoma going to the petrous area of the temporal bone. Then we have to, for the approach of the petrous apex, we have to perform a radical mastectomy. In cases of glomus tumor, in cases of carcinoma of middle ear, radical mastectomy followed by radiotherapy is the alternative to the en bloc removal of temporal. Now, steps are almost the same, but the facial ridge is lowered, the bridge and buttress exposure, and everything is like that only. We do a wide meatoplasty and obliteration of cavities, if required, is done. So how do we do it? This is posterior meatal wall, which is removed. Facial nerve lies exposed. The whole middle ear mastoid is formed as a single cavity. Only the stapes footplate, some stapes footplate is left. Dressing, antibiotic, and cavity care. Usually, the cavity epithelializes in 3 months, but it should be checked every 4 to 6 months in the first year and then annually. So, removal of any debris or infection can be there. Any granulation which delays in epithelialization is removed or cauterized. Complications are many. First is facial paralysis, perichondritis, injury to, told you, neurosigmoid sinus, labyrinthitis, severe conductive deafness after radical mastectomy is a sequelae, permanent sequelae, and there will be permanent cavity problems. Okay. Now, for overcoming the problems of radical mastectomy, we modify that operation in which we try to preserve as much as hearing mechanism as possible. The indications are cholesteatoma confined to atic and antrum, localized chronic otitis media, irreversibly damaged tissue are removed, preserving the rest to conserve or reconstruct the hearing mechanism. Anesthesia is usually general, but sometimes local anesthesia can be used in select cases. Position is same as the cortical mastectomy, and steps of operation are almost same as the radical mastectomy, but the facial ridge is lowered. We reconstruct the hearing mechanism. We try to preserve the tympanic membrane, part of the tympanic membrane which is normal, and try to preserve the ossicles which are normal. We do not remove all of the ossicular chain. We do not close the integumentary orifice. We try to open it up. We only remove the cholestoma, granulation, and healthy mucosa. Okay, and meatoplasty and closure wound is same as in the radical mastectomy. Now, last one, myringoplasty. Myringoplasty, as I've told you, is only the closure of perforation of past insa. It is known as myringoplasty. It has the advantages of restoring the hearing loss. It is the most commonly performed operation in our country, and every student must be fully aware of the myringoplasty. It has the advantages of restoring the hearing loss. It checks the reinfection from external canal and second tube and checks the aeroallergens reaching the exposed material mucosa. Okay, so myringoplasty can be combined with ossicular reconstruction, then it will be called a tympanoplasty. Contraindications, when we do not do a myringoplasty, if there is active discharge from the middle ear, the patient has nasal allergy, it should be brought under control before the surgery. The patient has arthritis externa, it should be treated before surgery. The growth of squamous epithelium into the middle ear. In such cases, excision of squamous epithelium from the middle ear or a tympanomastoidectomy may be required. If the squamous epithelium is grown into the middle ear, it means there is formation of cholestoma. Going to the formation of cholestoma, so the tympanomastoidectomy will be the better surgery. When the other ear is dead or not suitable for hearing and rehabilitation, the myringoplasty is contraindicated because you may injure this ear also. So the patient may become complete deaf. In children below 3 years, you do not routinely do not perform it. Local or general, usually the former is preferred because it is a small surgery. Usually we use temporal fascia, which is the most common grafting material for the repairing brain, but we can use the perichondrium from the tragus, we can use the tragal cartilage, we can use vein, we can use dura, we can use autologous vein also. Okay. Incision for exposure of tempering brain depends on the size of ear canal. It may be endomeatal, endoral, or postoral. Technique, there are two techniques, underlay and overlay. Underlay technique, in this we harvest the graft, we prepare the TM for grafting, we remove the edges of the perforation. We give an incision along the edges of perforation and a ring of epithelium is removed from the perforation. So the rounded margins of the perforation becomes bare, and uh, we also remove a strip of mucosal layer from the inner side of perforation. We inspect the middle ear, we raise the flap, inspect the middle ear and inspect the mobility of the ossicular chain, and we ensure that no squamous epithelium has grown into the middle ear. Then we do a underlay grafting. We pack the middle ear with gel foam. We proper size graft is placed so that its edges extend under the margins of perforation all around, and a small part also extends over the posterior canal bone. Okay, we put the graft under the margins of perforation. This is the difference between overlay and underlay. Same thing is there. Graft is placed on the outer surface of the TM. In this technique, we do everything similar. We do make a incision in the meatus. We make metal skin place करते हैं. We place the graft on the outer surface of the TM. A slit is made in the graft to tuck it under the handle of malleus. Then the metal skin removed earlier is now replaced, covering the periphery of the graft. Ear canal is packed with the gel foam. So do it over the perforation margins. See, this is the underlay technique, raw bone, and replace the skin. Sorry, overlay technique. Okay, we took out this skin, put a temporal fascia graft, tuck it under the malleus handle, and replace the skin. Post-operative care is similar. Stitches are removed after 5 to 6 days. Ear pack is removed 5 to 6 days, and patient is seen at 3 or 6 weeks after operation. Usually, graft takes up after in 3 to 4 weeks, but complete visualization takes around 6 to 8 weeks. Complications in underlay technique: middle ear may become narrow. Graft may get adherent to the promoter. It means the graft may medialize, can go in, and sometimes the graft may lose contact from the remnants of tympanic membrane anteriorly, leading to the anterior perforation. In the overlay technique, the problems will be different. There will be blunting of anterior sulcus because you are putting it like this. You are putting it, and sometimes this sulcus is lost. Sometimes this groove is lost. So, and sometimes the formation of umbilical valves is sometimes if you forgot to remove all the squamous epithelium from the margins. And in this underlay technique, graft may medialize, and in overlay technique, there are chances of lateralization of graft. Now, what is the tympanoplasty? Tympanoplasty, I have already told you, it is to eradicate the disease in the middle ear and to reconstruct the hearing mechanism. It is maybe combined with mastectomy if the disease process demands. Now, what are the types of tympanoplasty? Types of tympanoplasty are many, but there are many classifications. But I'm going to tell you around only the Bullstein classification, which classified it into 5 types. Type 1, when the defect is only the perforation of tympanic membrane, which is repaired with a graft. It is also the type which is synonymous with the laryngoplasty. Type 2, when there is a perforation in the tympanic membrane with erosion of the malleus, handle of malleus. Then the grafting material is placed on the incus or remnants of the malleus. Type 3, the both malleus and incus both are absent, both are necrosed. The graft is then placed directly on the stapes head. It is also called laryngostepidiopexy or columella tympanoplasty. Type 4, only the footplate of stapes is present. It is mobile, but all of the ossicles are destroyed. Then it is this type 4 trypanoplasty. It's posed to the external ear. Its graft is placed between the oval and round windows. A narrow middle ear cavum minor is thus created to have an air pocket around the round window so that the vibrations from the stapes go to the uh, round window. Now, in type 5 cases, the stapes footplate is fixed, but the round window is functioning. So we make another window in the horizontal semicircular canal and covered it with the graft. It is also known as fenestration operation. See, this is the type 1 tympanoplasty. You put a graft over the malleus. In type 2 tympanoplasty, malleus is destroyed, malleus under is destroyed. You put a graft over remnants of malleus or incus. In type 3 tympanoplasty, both of the malleus and incus are destroyed. We put a graft over the stapes. In type 4, the stapes is also destroyed. Only the footplate is remaining and it is mobile. We put a graft over the footplate and the this we make a air pocket for the round window, and sometimes this oval window is fixed. The stapes footplate is fixed. We create another opening in the horizontal semicircular canal. We put a graft over it, and patient this is also known as fenestration operation. So, what are the other procedures which are done, which we do for the repair of tympanic membrane perforation? We do a splintage, we do cautery patching, we do fat graft laryngoplasty. Splintage is used in fresh traumatic perforation. If you get a case of traumatic perforation which is fresh, came next day to you, the torn edges of perforation, they are carefully everted under the microscope and splinted with the absorbable gel foam placed in the middle ear. You go through the tear, put the absorbable gel foam, and smaller tears can be splinted on the outer surface with a piece of cigarette paper, gel film, or silicone sheet. This will heal the timpanic membrane perforation. Sometimes the small long-standing central perforation, very small long-standing central perforation, we can do a cautery patching. This procedure, margins of perforation are cauterized with trichloroacetic acid or silver nitrate to remove the epithelialized edges, and then supported with a cigarette paper moistened with 1% phenol and glycerin. This procedure can be repeated at 2 weeks interval. Instead of cigarette paper, other materials such as styrene strips, gel film, or silicone sheets can also be used. In fat graft varicoplasty, it is also used to close the small perforation. After local anesthesia, edges of perforation are fashioned with 1 millimeter hook, and inside of perforation is also stepped. A small piece of fat harvested from ear lobule is plugged into the perforation like an hourglass. Over a time, the fat graft adheres and closes the perforation. These are my slides. These are my slides, and if you have any question, I will be very happy to answer it. Participants, if you have any questions, I will be very happy to answer it.
Thank you very much, Dr. Hitendra. Trainees, you may type your questions, comments in the chat box.
Okay. Why the incision is given posterior quadrant? Okay. Now the first question: why the incision is given in the posterior inferior quadrant, or in case of ASM, it can be given into the anterior inferior quadrant only, also, but the posterior inferior quadrant is the chances of giving the more conventional approach is posterior inferior quadrant, but it can be also be given as a radial incision or in the post anterior inferior quadrant also. The Bondi's procedure from Dr. Kanaka Kumar, telling you, the Bondi's procedure is the procedure in which we extrudize the part of we do a extrusion of in the case of cholestroma, but we do not try to go to the middle ear. If the middle ear mucosa looks normal, then it is known as Bondi procedure. But the procedure usually it has some fallacies because we can leave the disease in the middle ear. So this procedure is not done nowadays, and I have not included in my lecture also. It is of historical importance. Sometimes we do it. Let's check. See, for the beginner, I would suggest anybody, any resident, any students who is starting his career, do a mastectomy from outside in. Because when you do a mastectomy from outside in, you are first you are going to the McEwan's triangle, you are seeing it, and you are drilling in it. You know you have reached the mastoidentrum, then you try to find out each and every landmark and go by those landmarks. In inside out, we try to follow the cholestroma from its origin. Okay? But sometimes what happens, if you are not that much versed with the middle ear anatomy, you can injure the facial nerve if it is located laterally. You can injure the ossicles. So it's safer to perform a outside in procedure in if you are a beginner. But inside out procedure is very beautiful. You should do it in each and every cases if you are comfortable. And I personally do inside out, each case inside out. I do not do outside in. So type 3A, type 3B, type 6 tympanoplasty, these are not classical Woolstein classification. These are modifications of Woolstein classification. I have not included that in my lecture to not to confuse all of my audience, because I honestly do not know what is the uh, what is the profile of my audience or my students. But uh, I think I should have been more elaborative in giving you the types of tympanoplasty. I might improve upon that. But right now, the classical Woolstein classification already mentions 5 types. Uh, Anything else? Small mastoid kidney. See, I've told you canal mastoidectomy in a small mastoid cavity. Uh, when you do a small mastoid cavity, open up a mastoid, you see the mastoid is closed. You have a very small mastoid cavity. You want to go with the canal wall up mastoidectomy. But what are the problems with the canal wall up? Canal wall up has problems because of the you are not able to see the uh, प्रॉपर एडिटस पार्ट जो एडिटस पार्ट है आपका जो अंडर सरफेस ऑफ द एडिटस है जो एटिक का अंडर सरफेस है दोज यू आर नॉट एबल टू इंस्पेक्ट सो small mastoid cavity or big mastoid cavity doesn't change your outlook going for the canal wall up canal wall down. Canal wall up, you can still do it if you're comfortable, but canal wall up has chances of leaving the disease. So it is better to go with the canal wall down procedure. If you are expecting a small mastoid cavity, you should go inside out, not outside in. Okay. Well, means small mastoid cavity does not, the case of small mastoid cavity, if you get a small mastoid cavity, it does not qualify to go for the canal wall of mastoid. Anything else? I would suggest everybody participates. Ask me. Ask whatever you think. Mr.
I think no. Yes, there's one more question.
What is vascular strip? Yeah, this is a very good question from Hitendra. Uh, uh, the vascular strip concept was there in the beginning when we try to do a overlay tympanoplasty. When we used to do a overlay tympanoplasty, the vascular strip concept was there. We do a vascular strip, we give incisions on the areas where the vessels of the external aortic canal comes. Okay, so we try to preserve those vessels so that the vascular supply uh, is intact. But overlay tympanoplasty is almost replaced by the underlay tympanoplasty. So we do not actually do a vascular strip incision. But what is it? We do. Let me again go to my okay, PowerPoint presentation. Okay. Yeah. See, this is the ये this is the whole of the ये this all has been lifted up and put it the whole of this has been put up over the in this direction, in the superior direction. Okay, let me just use my pointer. Yeah, this whole of this the tympanomeatal flap has been lifted up and it is attached to the malleus handle only and it is placed superiorly. this tympanosquamous suture line and tympanomastoid suture line. These are the two suture lines from where the vessels enter into the tympanomeatal flap. We try to preserve these. Okay, this is known as the vascular strip incision. Otherwise, right now, nowadays, when we not, we are not concerned with the vascular strip because we usually do the underlay tympanoplast. Okay. Vijay Rawatji, why retraction pockets are more common in posterior superior quadrant. So this is the very easy question and very easy answer because you see the mastoid is located in the posterior part of the posterior aspect of the middle ear. The aretus is located in the posterior superior quadrant, posterior superior part of the attic. Okay, from where it is connected. And third thing, the your attic or pars flaccida, it is flaccid, it's not taut. So it has more chances when a negative middle ear pressure comes, when there is a negative middle ear pressure, the tendency of uh, retraction is more in the attic. So because of that, retraction pockets are more common in the posterior quadrant. Active discharge of ear, yes, it is a contraindication for tympanoplasty. It's not a contraindication if it is having active discharge because of cholecystroma. Combined approach tympanoplasty, some people may call it tympanomastoidectomy, combined approach tympanoplasty or CAT. So this is same. We do tympanoplasty with mastoidectomy. We do mastoidectomy from the posterior aspect and do a tympanoplasty from the canal. Difference between facial bridge and facial ridge. Facial ridge is whole of the part of the bony canal wall which lies over the vertical segment of the facial nerve. Okay, and facial bridge is the part of bone which overlies the aretus and short process of incus and facial nerve, the curvature of the facial nerve. Okay, to what level? Ideally, lowering of facial ridge should be done up to the level of facial nerve. It is the recommended to lower the facial ridge till the level of facial nerve, till you see the bony facial canal. Anything else you want to ask?
So I think no more questions. Dr. Hitendra, thank you very much for the presentation. And there's one more question last. Can we take this last question?
Yeah, why not? Dr. Kamika Kumar is asking persistent discharging ear. See, persistent discharging ear is a problem. If there is only simple perforation in the past tensor, you just try to do the proper oral toilet, proper antibiotic treatment, proper local treatment, the discharge should go away. Okay, and uh, if it does not go away, you should see for the hysterectomy function. You should see for the allergy. Okay, upper airway allergy and poor hysterectomy function contribute for the persistent discharging ear in a safe perforation in a safe ear. Safe ear means chronic suppurative otitis media of mucosal type. Okay, in chronic suppurative otitis media of squamosal type, the discharge will be persistent no matter how and what you try. So it's the treatment of spermacell type is only surgery. You should go for surgery straight away when you see a case of cholestoma, the or retraction pocket, cochlear reserve. Dr. Kanaka, the cochlear reserve actually was not the part of my topic, but since you have asked, I will try to answer that. So, cochlear reserve is the part of hearing which is there after you have got the hearing loss. So, we see for cochlear reserve in cases of bilateral chronic suppurative otitis media, and if there is having severe conductive hearing loss or severe sensory hearing loss. So we see for cochlear reserve so that we can decide upon the candidacy and the laterality of the surgery.
So thank you again, Dr. Hitendra Prakash Singh, for the presentation. Thank you very much, trainees, for joining us.